whether you're working as a generalist or whether you're working as a subspecialist, radiology is completely now, especially nowadays, the first port of call when a patient comes, you're doing the diagnostic work, trying to answer the complex question, and you're the first person to be able to give those answers to the physician and to the patient. So I think it's a hugely important job. It provides immense opportunity, and if you enjoy the work, then it's a great specialty to pick.
Well, thank you for being with us today.
Thank you for having me.
If you can just give an introduction of yourself.
I am a radiologist at MIC. In terms of training, I did my training both in London and Edinburgh. I then moved over to Canada, did some fellowships in both Toronto and Ottawa, and I found my home here in MIC.
What's your subspecialty?
I'm predominantly a body imager. I do a lot of body MRI. I also do a lot of body procedures. So usually with image guidance using ultrasound or CT.
Do you work mostly in the hospitals, or are you at our clinics, or where are you mostly working?
I do a bit of both, but my expertise sort of puts me more towards the hospital with my inclination to do a lot of the cross-sectional imaging and also the procedural side. But I do rotate through the clinics as well.
And can you talk a little bit about your position as an assistant professor?
For sure. So I hold an assistant professor title with the University of Alberta. That gives me a lot of opportunities. For me, one of the most important is teaching the residents. I love teaching the residents. I love seeing them progress through their training and becoming expert radiologists. So that by far is what I attach the most meaning to. If you can teach a resident to understand a concept better, that can ripple out to thousands of patients over their career. And if they teach the same concepts, the benefit to patients is absolutely immense.
Mm-hmm. Have you noticed kind of differences in trends of what you're teaching over the years?
Not really. I sort of tend to focus more on the body imaging side, but what I have found over time is that I've refined the way I teach. I've understood from feedback what works, what doesn't work, and I try my best to teach in a way that would have the greatest impact on the resident, have the greatest clarity. Sometimes that takes more effort to do, but I think it's well worth it.
Is there any new technology that you have seen kind of in the last couple of years?
We are constantly evolving. In terms of my practice, I think that there hasn't been a huge amount of change in the last few years. What we use at the hospital and what we use at the clinics is already like state of the art. There are some new things that are coming to us, like photon counting CT, and we're very excited about that. And I'm waiting for that to start using that very soon.
Mm-hmm. How many students do you usually see come into the program?
So we have about 5 or 6 residents a year, and I like to stay involved in their training. Sometimes we have bigger years, sometimes we have smaller years. Mm-hmm. So, on the whole, where we have about 30 in the cohort at a time, and they're all at different levels, and they all have different needs. And, over the time that I've been here, I kind of understand those, what we should expect from somebody who's in the second year or third year and such forth.
For other programs, like other medical programs, is that kind of, it's usually 30 students?
So we also have other students that do come to our, we have medical students who want to learn more about radiology. Some are considering a career in radiology. So we have, we sometimes have them sit in on our reporting sessions. In terms of classroom teaching, we all have a responsibility to do some of it. So I do a few sessions a year. Those are usually to our own residents. We also have our technologists, our CT technologists, our ultrasound technologists that occasionally ask us to give them lectures on topics that they find interesting or they want to know more about, and we're happy to do that.
What is the most critical skill you like to teach your residents?
Well, it varies from what we're doing. So, for example, if we're doing procedures, I like to teach them various things. Like, I think the first thing is about safe practice. And that usually, goes over what we can do, what we can't do. We also focus on pain management, right? We want these procedures to be as painless as possible. So over time, and with experience, I've learned a few of these things, from what makes the procedure safer, what can we do to improve sort of pain control, and I try to teach that to residents. I think that's like the most important from the procedural side. When we're looking at the diagnostic side, there's, with radiology, you need a lot of, there's a lot of knowledge that needs to be accumulated over a period of time. And that translates to, accurate diagnosis. And it's teaching the residents to move from where they are when they join us, at the PGY2 level to being expert radiologists at the PGY5 level, teaching them, how to, imparting the knowledge so they can have the accuracy towards the end of the program is phenomenal.
Such a commitment to become a radiologist or a doctor of any kind, really.
Absolutely. Yeah. And an immense privilege as well.
Are they taught kind of the different areas, or is there usually specialties that they learn while they're resident?
So I only teach them a small portion of the program that they need to know. Radiology is vast, right? And the way we practice at MIC, a lot of us are subspecialists. They have to learn besides the body imaging that we teach them, they have to learn neuroimaging and musculoskeletal imaging, breast imaging. We talked only about a very small portion of the procedures that I've done. There's a whole range. There's vascular intervention, there's neuro intervention, and they rotate through all of these. Obviously, they have to learn their pediatric imaging. So we all touch on them in a small way, but we hope that collectively contributes to a fantastic experience for them. And as radiologists, I think that being involved in something like teaching and research gives us the ability to keep learning as well, because things do change, and when you're in the position where you're actually teaching, you have a duty to make sure you're also up to date.
I wanted to talk to you because when I Googled your name, most of what comes up is your work with protocol for cancer. Can you talk a little bit about your work with that?
Absolutely. I think cancer imaging is another area where I feel very strongly about, and whenever there's an opportunity to get involved, I do so. And the way we do that is we have a lot of what we call multidisciplinary rounds in the hospitals, and that's where all the doctors come together to discuss cancer cases. And as an MIC radiologist, I get lots of opportunity to participate in those. More recently, I was invited to be part of an expert panel to devise, the best imaging guidelines for those with suspected cancer. And it was an initiative by the Canadian Association of Radiologists. And I was lucky enough to be invited to be the chair. And that goes to show how MIC is trusted to set up these national guidelines. And that was successfully completed and published last year. And I think that will have an immense impact, because when you have any physician looking to investigate a particular type of cancer that they suspect, for example, pancreatic cancer, they may be, with a myriad, they may see a myriad of potential imaging pathways that they could select. So these guidelines are meant to streamline that, to make sure that the right test is picked right at the very beginning. And that would help with, getting the correct diagnosis, avoiding, unnecessary use of resources, and ensuring that the patient gets the next step of their pathway as quickly as possible.
What is the protocol if cancer is found in a screening?
Yes, so we discussed this. So the way the expert panel worked was we involved everybody. We involved other radiologists. We involved surgical oncologists, medical oncologists, family physicians, also patient representative and epidemiologists to look at the research. And we found that for the Canadian context, if you're suspecting, for example, in primary care, if you have a patient with suspected pancreatic cancer, the next step would be to go straight to a CT.
Mm-hmm. Yeah, pancreatic cancer, I didn't realize Dr. Funk said one time about how the chances of living isn't very high if you catch pancreatic cancer late.
Yes, that is true. That being said, there is a spectrum of different types of pancreatic cancer, and most commonly that would be the scenario that would be faced. But there are some other types that can do better with treatment.
What are those types?
So we have different types. So we have neuroendocrine tumors, for example, and depending on their stage of presentation, there may be treatment options available to them that may allow them to live longer than we discussed. And there are also other things that we can see on imaging in the pancreas that can actually end up being benign. So, and that's very useful to also point out. However, the most common form of pancreatic cancer, and especially if found late, has associated with it, a prognosis that is obviously not very favorable.
For different types of cancer, once we've gone through all of those steps and they are timed to do like some sort of procedure, what are the types of procedures that you do in the hospital?
Let's say we have a case where we do a CT scan and we find that there may be, and we'll keep with the same sort of theme. Let's say we find that there is a mass in the pancreas. Sometimes we see associated with it lesions within the liver. And, strictly at that time, they're indeterminate, but we are suspicious that they're potentially related. So one thing we can do is arrange for a biopsy of one of those. And so they come back to our department for that. Usually we do these under ultrasound. So they come back to our department for that. We have a look at them under the ultrasound. We decide which is the safest one that we could target, and then go through the procedure with the patient, and then using, the routine, the sterile technique, the local anesthesia, we're able to acquire samples using the ultrasound from the liver, and hopefully that can help us answer these questions.
And is that minimally invasive compared to previous?
Yes. So everything that uses imaging guidance is minimally invasive because we're using the imaging to help us guide needles, and usually we're approaching things through the skin. So whether it's draining a collection, whether it's taking a biopsy, and this has, and this has been going on for quite a while now, but it has transformed care from the aspect of needing surgical procedures to do some of those things.
And you've mentioned a little bit of some of the quality initiatives you've led to improve patient safety or imaging. How do you use some of your students to help with these procedures or these safety initiatives?
Oh, yes. So that's a good question. So we have the residents do what we call quality assurance projects or audits every year. And I like to get involved in those. So those are, really sort of, they're not research, they're, projects designed to make sure that we're meeting a certain standard generally. For example, when we have patients coming into the hospital for procedures, the procedure always has to be explained to them, and they have to provide their consent, which and that should happen every time. And it does happen every time, but do we do the documentation every time? So that's nice, to get a resident who's in their training to look at this information, because they can appreciate how important that process is and how important a documentation is, and they get involved and invested in something like that, and they're able to provide us with an opportunity to understand how well are we meeting this standard. So it helps both the resident and it helps us, because we try to maintain the best possible quality through doing these quality initiatives.
And how else are residents hands-on with their studies and with the
Yes.
work you do?
So, they when they're with us, it's usually all hands-on, because they're either reading a case or helping with a procedure. And so it's really all hands-on while they're in the department. They have to do their private study. But with us, when they're on service, it's all hands-on, and that's a very effective way of learning.
And when they're have you worked with some of the residents at MIC in our clinics?
Yes, so the residents that are affiliated with the University of Alberta, we teach them at the hospital, we teach them, they also come to the clinics, we teach them there as well.
What is that like to have kind of residents at MIC? What is kind of like the benefit of that?
Oh, I think that's immense benefit, and I think it's great that MIC supports these initiatives, because when you have a resident in training, they eventually have to make a career decision as to where they want to work. And MIC is very unique in that it's a hybrid practice where we can work on both spectrums. You can work in the hospital and you can work in the clinic. There are other practices which are entirely clinic-based. And it may be that a resident wants to explore that, or it may be that a resident wants to explore, a more hybrid way of working. And MIC is unique in that it gives their residents that opportunity to test out what they really want to do. And I think MIC going the extra mile to allow these residents to do that is a great thing.
Mm-hmm. You mentioned kind of before, but you said there's 30 students typically. Is that who usually do they graduate together, or is it kind of all?
Yes, so they're at different stages. So in each year we have about 5 or 6. So we'll have those graduate for example, at this year we have, I believe it's 7. So 7 will graduate at the end of this year, and then there'll be the next cohort.
That's actually not a lot.
No.
I feel like you would expect a little bit more, but
I think it's more of a constraint in how many we can actually teach, rather than the demand. I think it's a very sought after specialty.
okay.
But really it's how many can we accommodate, and that's constantly being worked on by not only, that's also a function of the university. So, they're constantly trying to improve access to training and train more specialists, so that because there is a need in the province.
Mm-hmm. How many schools are there that provide radiology?
In Alberta, it's just the University of Alberta and the University of Calgary.
Okay. And then in the country, do you know?
Oh, yes. So there's programs all over the country. So usually every province has at least 1 or 2 programs.
What is the most rewarding part about seeing a student grasp a complex concept for the first time?
Yes, no, it's exceedingly rewarding, especially if you've been involved in teaching some of that concept to the resident. A lot of work in radiology is very complex, and sometimes it is, it's difficult to fully understand something you may have read in a textbook until you see it actually on a patient's case, which finally makes it memorable to you. And I love showing residents cases which have made those kind of things memorable to me, and watching them then understand that concept and having a smile on their face is wonderful.
How did you remember all those complex concepts?
Yes, I think what I always tried to do was to try to understand it from from their first principles, and usually that's by looking at cases. So I find cases to be a very, very good way of learning. And I keep a huge data bank of those.
Yeah.
And I love showing them to residents, whether it's preparing for an exam or whether it's trying to teach them a specific area that I've been assigned to teach them. I think that's a great way of delivering teaching.
That is almost the last question I have for you. Usually I like to end it with, do you have any advice for new residents?
Oh, yes. So I think radiology is a fantastic specialty. I think it allows you to do, it offers a lot. You can choose between being diagnostic or being procedural or having a combination. You're able to work by choosing either working more as a generalist, or you can actually focus on certain subspecialties. I think it's very unique in that way. Not a lot of specialties lend themselves to that kind of opportunity. And when you are working as, whether you're working as a generalist or whether you're working as a subspecialist, radiology is completely now, especially nowadays, the first port of call when a patient comes, you're doing the diagnostic work, trying to answer the complex question. And you're the first person to be able to give those answers to the physician and to the patient. So I think it's a hugely important job. It provides immense opportunity. And, if you enjoy the work, then it's a great specialty to pick.
Okay, that's all the questions I have for you. Thank you.
Well, thank you.